This presentation will cover female sexual dysfunction and genitourinary symptoms of menopause. This is an enormous topic. I have tried to present the high-yield topics for the purposes of the CREOG exam. Please feel free to reach out if you'd like more information on a specific topic. Historically, a normal female sex response was thought to be a linear process that resulted in orgasm. We now know through many high-quality studies that this is not true. A normal female sexual response is often nonlinear and encompasses a variety of sequences. This is a figure that's meant to demonstrate some of the sequences and how they interplay with one another. Key parts of this are anticipation and desire or drive, arousal, sexual stimuli and context, arousal, willingness, and obviously motivation for sex. There are several types of sexual dysfunction, and we'll review the highest yield disorders. The first is female sexual interest and arousal disorder. This replaces hypoactive sexual disorder, desire disorder. Many women who say that they lack a sex drive or have decreased libido mean that they have lost the physiologic desire for sex. This means that they often will describe thinking about sex, but their thoughts are about avoidance or about initiation of a sexual activity only for the purposes to preserve a relationship with their partner. It's defined as a lack of or a significant decrease in at least 3 of the following: interest, sexual or erotic thoughts and fantasies, initiation of sexual activity, excitement or pleasure during all or almost all sexual activity, or genital or non-genital sensations during sexual encounters. It's critical to elicit comorbid conditions when diagnosing sexual interest arousal disorder. Common etiologies for this disorder are things like anxiety, diabetes, depression, intimate partner violence, a history of sexual abuse, postpartum period, i.e. breastfeeding and obstetric trauma, relationship distress, substance use disorder, and common medications such as psychiatric medications, SSRIs, antihypertensive medications, histamine blockers, and other hormonal medications. The next disorder is female orgasmic disorder. This is defined as a marked delay in marked infrequency of or absence of orgasm, or markedly reduced intensity of orgasmic sensations in almost or in all occasion of sexual activity. These symptoms must be present for a minimum of 6 months. The next is genitopelvic pain or penetration disorder. This is usually referred to as vaginismus and dyspareunia. It's defined as a persistent or recurrent presence of one or more of the following: difficulty in having intercourse, marked vulvovaginal and pelvic pain during intercourse, marked fear or anxiety about vulvovaginal pelvic pain, anticipation during or resulting from vaginal penetration, or a marked tensing or tightening of the pelvic floor muscles during attempted vaginal penetration. It's important that these symptoms be present for a minimum of 6 months, and again, it does not need to involve penetrative intercourse. Substance or medication-induced sexual dysfunction. This is defined as a disturbance in sexual function that has a temporal relationship with the substance or medication, a dose increase, or the discontinuation of a substance or medication. Some common examples are things like anticholinergic drugs, hormonal medications, cardiovascular medications, or psychiatric agents. Substances include but are not limited to things like alcohol, marijuana, and narcotics. It's important to note that healthcare providers should never give the advice to consume alcohol or other substances in order to alleviate or attempt to reduce sexual dysfunction. Pregnancy-related sexual dysfunction is often in the postpartum period, but doesn't have to be. Common etiologies are secondary to trauma, either from a cesarean delivery, operative delivery, an episiotomy, or perineal lacerations. Breastfeeding leads to decreased estrogen and vaginal dryness, which can result in pain with intercourse. And then, of course, there's a ton of maternal factors that can lead to postpartum sexual dysfunction, including but not limited to chronic disruptive sleep, role changes, relationship issues, newborn health issues, psychosocial adjustment to parenthood, and then body changes. Postpartum depression is commonly found in women with pregnancy-related sexual dysfunction and intimate partner violence. The last disorder we'll review is menopause-related sexual dysfunction. This describes genital, sexual, and urinary symptoms associated with declining levels of estrogen and other steroid hormones during menopause. Symptoms include bothersome vaginal dryness, burning, irritation, decreased lubrication, and pain with intercourse, and urinary urgency, dysuria, and recurrent UTIs. It's estimated that about 50% of women who are menopausal have at least one of these symptoms. A high yield for our upcoming exam is to remember that the gold standard treatment for this is intravaginal estrogen. There are many treatments for female sexual dysfunction. I wanted to review some of the more commonly encountered treatments. I think it's also important to understand that a lot of the research on these topics is lacking. So when ACOG says that something has a lack of evidence or should not be routinely recommended, that may or may not be the correct thing to do for your specific patient. And I would encourage all of you to refer patients to a specialist in sexual dysfunction who is up to date on the current literature and research. Cognitive behavioral therapy and mindfulness-based therapy, couples therapies are recommended as part of the routine treatment of female sexual dysfunction. Transdermal testosterone and transdermal DHEA has been shown to be effective for postmenopausal women with female sexual dysfunction. Vyleesi is now an FDA-approved treatment for hypoactive sexual desire disorder in premenopausal women without depression. Important to note that there is a black box warning about the alcohol use during treatment because of an increased risk of syncope and hypotension. Viagra, although used for men, has not been shown in the literature to improve female interest in arousal disorders. It's not recommended for use outside of clinical trials. Bupropion is an antidepressant that has been shown in high-quality research to have a dose-dependent response on female sexual function index scores. So the higher the score, the less disorder essentially one has. So that is a good thing. And then there are many devices on the market, things like the Lilo and Sona and the Eros, which are kind of special vibrators or devices aimed to increase blood flow and engorgement of the clitoris with the goal of improving arousal and orgasm. Also, I think probably the most important is patient education. There's plenty of amazing resources available online, including books, podcasts, and videos to help patients navigate this difficult area. And important to recommend the simple things like lubrication and also vaginal estrogen, again, especially in postmenopausal women or women with medications that may decrease total body estrogen or free estrogen levels, And a mainstay of this treatment should be pelvic floor physical therapy, plus or minus the use of dilators. Patients can buy dilators, also known sometimes as wands, online for home exercise.